Ladies. Okay. Hello and welcome. My name is Gwen Driscoll. I am the Director of Communications here at the UCLA Center for Health Policy Research. It is September, so we would like to especially welcome our returning UCLA students as the fall quarter begins. Now get to work. Just kidding. All right, we have a date for next month's seminar, October 31st, but we have not quite yet nailed down which of the two pending blockbuster topics that will be our headliner. So we expect to make an announcement in the next week or so. So please stay subscribed to Health Policy News, the Center's wonderful monthly e-newsletter for imminent updates. But whatever topic we choose, rest assured, we promise we will make our experts dress in costume. You all can dress in costume too. Again, that's October 31st at noon, and yes, treats, but no tricks will be served. As for today, we will be recording today's seminar, and it will be placed on our website at the address you see at the top of this slide. If you would like copies of today's slides, please email me at the middle address, gdriscoll@ucla.edu. And again, please subscribe to our e-newsletter for all the breaking news and announcements about our latest research and data. Please note, we'll also have a brief question and answer period at the end of today's seminar that I will moderate. Okay. 3 out of 5 of the poorest, sickest residents in Los Angeles County have rejected a managed healthcare program meant to improve their access to health services, giving Los Angeles at 19% the lowest enrollment in the state. The program, called Cal Mediconnect, was designed to better coordinate medical, mental health, and other healthcare services for dual eligibles. These are the approximately 415,000 medically frail older adults or severely disabled young Californians who qualify for both Medicare and Medi-Cal benefits. So, why are older adults and the disabled who qualify for this program opting out? In conjunction with a new policy brief published today and available on the Center's website, and that is healthpolicy.ucla.edu, Center research scientist Catherine Keatsman and graduate student researcher Kate McBride will describe some of the fears, misinformation, and other concerns that dual eligibles expressed to her, both in one-on-one interviews and in focus groups. Catherine has been documenting their reactions to the rollout of Cal Mediconnect as part of a Robert Wood Johnson-funded 2-year project called the Choice Project. It's part of broader career interest in the health and social care needs of the most physically, socially, and financially vulnerable of older adults and others who rely on a complex and fragmented system of care. Kate is one of the elite crew of graduate students from the UCLA Fielding School of Public Health who is gaining practical policy experience here at the center as one of our graduate student researchers. She's a doctoral student in the school's Department of Health Policy and Management, whose work has concentrated on healthcare costs, so she's a natural fit for this topic. Please welcome Dr. Catherine Keatsman and Kate McBride.
Good afternoon. Thank you, everybody who joined us in person and those who joined us online today. I'm really pleased to be able to talk with you about the CHOICE study. And CHOICE, in case you're wondering, it is an acronym. I have a thing about making acronyms. As a team, we like to sit around and dream them. And it actually stands for Consumer Healthcare Options, Investigating Cal Mediconnect Enrollment. And in the course of the next few minutes or the next hour, we'll talk to you about what that's all about. First, I'd like to acknowledge the support of the Robert Wood Johnson Foundation and to state that what we present today does not necessarily reflect their views. And then the study team involved in this was quite large and robust and wonderful. So I want to acknowledge the contributions of the team. The names are listed here. Our primary community partner, the Westside Center for Independent Living, and our community advisory group. And this was a group that includes 5 dual-eligible healthcare consumers and 5 representatives from health plans and community-based organizations here in Los Angeles County. And that includes LA Care, the Center for Healthcare Rights, the Personal Assistance Council of Los Angeles, Justice in Aging, and Anthem Blue Cross. So without the work of this group, this study would not have happened. So into the immediate research question overarching all of this. So we wanted to understand what are the factors that lead dual-eligible health consumers to enroll and remain in either a fee-for-service or a managed care setting. And I'm going to set this a little bit in context. First of all, dual-eligible consumers, often referred to as duals or medi-medis, these are consumers who qualify for both Medicare and Medicaid. And as Gwen indicated, these are among the sickest and poorest of healthcare consumers in the United States. They're the highest utilizers of health services and incur the highest costs. About 62% of consumers are over the age of 65 in this group, while the rest are younger adults with significant disabilities. This is also a very diverse population, with 44% representing racial and ethnic minorities. There are currently about 11 million duals in the United States, about 1.1 million here in the state of California, and more than 400,000 live here in Los Angeles County. So historically, Medicare has been the primary payer of medical services to duals through a fee-for-service model of delivery, while Medicaid functions as a wraparound, covering some of the out-of-pocket costs and services that are not covered by Medicare, such as dental and vision benefits and long-term care. And that includes both institutional long-term care and home and community-based services. So the Affordable Care Act, the current healthcare law, includes many provisions for the testing of new and innovative delivery models. The Center for Medicare and Medicaid Innovation hosts one of these demonstration programs, and it's the Financial Alignment Initiative for Medicare and Medicaid enrollees. So this initiative aims to align the financing and the delivery of Medicare and Medicaid benefits, which historically have been administered through really separate systems, and there's been very little coordination between them. So what about Cal Mediconnect? Cal Mediconnect is the demonstration program in California. It's one of 13 states that's actually implementing one of these demonstration programs. It was launched in 2014, and it's part of a larger California Coordinated Care Initiative. So Cal Mediconnect uses a capitated financing model where the state, the Center for Medicare and Medicaid Services, and a participating health plan enter into a 3-way contract. And the plan receives a prospective blended payment to provide comprehensive coordinated care. The goal of the Cal Mediconnect program is to provide seamless service delivery experience for dual-eligible consumers and to attain the triple aims of the healthcare reform, to improve quality, to achieve better health outcomes at a lower cost. So I want to tell you a little bit more about the enrollment process for this program, which started in 2014. So Cal Mediconnect used what's called a passive enrollment process for the first year of this demonstration. And what that means is that consumers, if they chose to opt out, they could retain their fee-for-service Medicare benefits, but still had to enroll in Medi-Cal managed care plan for all of their Medi-Cal benefits, including long-term services and supports, dental, vision, and transportation services. So consumers were mailed a series of notices. There were 90, 60, and 30-day notices in blue envelopes. That was the signature to look out for. And these envelopes and information asked consumers to either choose a Cal Mediconnect plan or opt out of the full program. Now in Los Angeles, there's actually 5 different health plans that offer the Cal Mediconnect program. So not only did the consumers have to decide whether to opt out and keep with their Medicare, if they decided to choose a Cal Mediconnect plan, they had 5 different health plans to sort of understand, what the offerings were from those different health plans. So it's also important to note that the enrollment, which is the main focus of this talk today, has actually really fallen far below expectations. As of August 1st of this year, only 28% of those who were eligible for this program in California had enrolled, and Los Angeles had the lowest rate of all 7 demonstration counties. There are 7 counties participating, with only 19% of those eligible enrolled in Los Angeles County. It's important to know that there's also significant language and racial ethnic differences in enrollment. The state stopped publishing these data about a year ago, but at that time in Los Angeles County, the highest opt-out rates were among individuals who speak Russian, Hebrew, Armenian and Farsi, and Korean. And then in terms of race and ethnicity, the highest opt-out groups were among Koreans, Chinese, Amerasian, and whites. Latinos and Hispanics were among the least likely of racial ethnic groups to opt out of this program, followed by Samoans. So we wanted to understand how these consumers make decisions about their health care fundamentally, and Cal Mediconnect provided us the venue in which to do that. So our aims were to learn more about how they make decisions and what matters most to them in their health care. We're interested in the types and sources of information that consumers access and make use of when they make their healthcare decisions, and then how they use this information. And then based on what we learned, we hope to identify better ways to communicate information about healthcare options and to better support consumer decision making. So a little bit about our approach. We used a qualitative and a community engaged approach. Again, as I mentioned earlier, we had a lot of partners and a big team. We partnered with the Westside Center for Independent Living, and we worked with our community advisory group to investigate the decision-making processes and healthcare preferences of these consumers. The community advisory group, we met bi-monthly through this 2-year project, and they assisted us on all aspects of the project, including the development of the data collection tools, the recruitment materials, analysis and interpretation of the data, and a plan for dissemination of the most relevant findings. And this was invaluable to our process, because as researchers here at UCLA, we were not in a position to really understand on the ground what the experiences of the community organizations, the health plans, and the consumers. So this was really a group that helped us understand what we needed to look for and what the best way was to approach that. We had 2 independent phases of data recruitment and collection. We first conducted one-on-one interviews with consumers. These were usually done in person. And then we conducted a series of 6 focus groups. And this was an independent group, so none of the same people were participated in the focus groups who participated in the interviews. The interviews were done between March and August of last year, and the focus groups were done between January and May of this year. So we asked consumers questions about how they get information about their options for healthcare and how they use that information to make decisions. We asked how they make health-related decisions, including the information used, the people that they consulted with, and the perceived risks and benefits of the options that were made available to them. We also wanted to understand how they evaluate and prioritize their healthcare options. We asked, what are the must-haves in your healthcare when it comes to their preferences, and what components do they value the most? In the focus groups, we also asked a series of questions about how these consumers would prefer healthcare coverage options to be communicated to them. What works best? How would they plan and disseminate information about healthcare options like Cal Mediconnect? So I'm going to talk to you a little bit about who participated in these 2 phases of the project. So our sample of 53 participants, interview participants, is predominantly female. Slightly more than half are over 65 years of age. And our group is fairly diverse. About 1/3 were African American, slightly less than 1/3 were Caucasian, about 1/5 were Latino, while the remaining participants identified as Asian, specifically Japanese, Chinese, and Filipino, and American Indian. We had the capacity to do interviews in both English and Spanish. The majority was done in English. 10 interviews of the 53 were done in Spanish. And actually, we had an ad hoc opportunity. 1 interview was done in Mandarin with the help of an interpreter. About 3/4, almost 3/4 of participants were U.S. born. In the focus group phase of the study, we conducted 6 focus groups with 36 consumers, and we thought very carefully about where to conduct these focus groups geographically. And we looked at our one-on-one interview sample to see what sort of geographic areas of Los Angeles County we may have missed. So we took effort to reach Antelope Valley, for example, and East LA, and make sure that we had a broader representation of consumers. Close to 2/3 of our participants in the focus groups were over the age of 65 and female. And these participants were also fairly diverse. We did have an increased representation of Latinos in the focus groups. That can be pretty easily explained. We had 2 focus groups that were conducted in Spanish. About 70% of the focus groups were US-born participants as well. So once we had these data, the way we worked with them, all of the interviews and the focus groups were audio recorded and then transcribed verbatim. We had the transcripts then were independently coded by at least 2 members of our research team. And these codes were developed inductively. We tried to stay as close to the words of the participants as possible. And then the team came together. We looked at these codes. We sort of reviewed and refined them and came to an agreement about what the definition of each code was. Then went back to the data and used those agreed upon codes to code all of the interviews in the focus groups. And then from that process, Atlas is a software program that sort of helps manage and organize large amounts of qualitative data. And that's the software program that we used. But through this process, we then identified sort of patterns and themes in the interviews across groups and across the focus groups. And then the emerging findings that came from the interviews, we actually sent back sort of a summary of the highlights of those findings to our participants, just to get further validation that what we were saying we thought was most important and emerging from these interviews resonated with them. And we did get concurrence from, we had about 25% of people who actually replied of the 53 interview participants, but they all agreed and then actually gave us even more information about what was important to them. So I'm going to turn this over now to Kate to talk about what we learned from our consumers.
So I'm going to speak with you a little bit about the study findings and some of our limitations. So through analysis of the participant narratives in the one-on-one interviews and a focus group, we identified 3 major themes to understanding the factors that lead dual-eligible healthcare consumers to either enroll and remain in a fee-for-service or managed care setting. So these 3 main themes were knowledge of healthcare options, perception of choice, and disruption to existing care. So the first one I want to talk to you about under the knowledge of healthcare options is the complexity of the Cal Mediconnect enrollment. This process was extremely overwhelming for dual-eligible consumers. As Catherine mentioned, they received notices in the mail, 90, 60, 30-day notices in a blue envelope. As we know, sometimes we throw our mail away, sometimes we don't know what the mail consists of, and then within those blue envelopes were very detailed packets of information about the process that was available to them, the options they had. So they had an option to choose between 5 different Cal Mediconnect plans in LA County. If they decided to opt out, they then had to also enroll in a Medi-Cal managed care plan. And so the detail within these blue envelopes and just the confusion from not understanding, navigating the healthcare process in general as a dual eligible is a confusing process. And so it was very complex for a lot of these consumers, and so the paperwork in general just added complexity to the entire process. And they were just frustrated in general about having to switch to a new plan and just general questions about why this change was happening and why they had to change their existing doctors. Another theme within this theme is the understanding of health plan options. A lot of individuals, like I said, were confused, and so when they received the blue packets in the mail, they weren't sure what their options actually were. They didn't realize that even if they chose to enroll in a Cal Mediconnect plan, they could disenroll at any time for any reason. They didn't realize that they had an option to opt out and just choose a Medi-Cal managed care plan and be able to maintain their Medicare fee-for-service services. So even just understanding what their options were was very difficult. And then the use and trust of Cal Mediconnect information sources. Within both the one-on-one interviews and the focus groups, I think primary care providers, their doctor's offices, and specialists were mentioned as the #1 information source. I think that had to do with the fact that most participants wanted to maintain continuity of care, so they went to their doctor's offices first to say, if I join this new plan, will I be able to continue to see you? Other valuable sources for consumers were community-based organizations, and they also utilized the Cal Mediconnect information hotline. That was a number provided within the blue envelopes that they received in the mail. And I just wanted to highlight a quote from one of our consumers in our study. This is from a one-on-one interview. And this has to do with she didn't fully understand the healthcare options available to her when she received the blue packet in the mail. No, I didn't understand that I could opt out of a CMC plan or that I had any choices. Like if I could disenroll after a certain time, I wasn't aware of that. So this woman, I actually interviewed her, and we spoke about the process, how confused she was when she received the information in the mail. She assumed she had to enroll just to remain compliant with California's Coordinated Care Initiative and everything that was going on in California at the time. She wasn't aware that she could have opted out of the program. But once she realized that she could no longer see her primary care physician anymore in this new Cal Mediconnect plan, and she also saw many specialists and had other healthcare conditions that required a lot of specialists in her network of doctors, she went back to her old doctor's office and who helped her disenroll from the program. So she actually sought help from her former doctor's office to help her with the paperwork to be able to disenroll. Another theme we found through participant narratives was this perception of choice. For most who were passively enrolled, which Dr. Keatsman mentioned, some participants didn't realize they were enrolled until they received a call from their new Cal Mediconnect plan, or they received a medical bill saying that they owed money because they had seen a provider outside of Cal Mediconnect. So because of this passive enrollment, participants were enrolled into a program really without their acknowledgement. So they felt that because of that, they had no choice in the process. There was also this perception of choice was also dependent on their level of understanding of Cal Mediconnect. For some consumers, we had some consumers in our study that were very, very engaged in the community and sought community-based resources, the Cal Mediconnect hotline, their doctor's offices. They knew who to reach out to, and so they were able to get the information they needed and did feel like they had a choice in the process. They understood what the process was going to be and how they could maintain their existing services. But for others who had more of a limited understanding of Cal Mediconnect, their perception of choice was they felt they were more constrained in what they could do. And thirdly, most participants, a majority felt that because Cal Mediconnect was a managed care plan, they definitely perceived this as a disadvantage and felt that there was a huge constraint in the types of specialty services they could access and other specialists they could see outside of the Cal Mediconnect network. And they just felt they also may receive lower quality of care. There's this perception that because they were low income, from a low income background, that doctors wouldn't want to contract with Cal Mediconnect because they serve lower income and vulnerable populations. So this is an example of one of our participants who felt that he did not have a choice in the process. He was passively enrolled in Cal Mediconnect. He was an older gentleman. He was a Filipino male, and he was basically just told from a phone call from a Cal Mediconnect plan that he was, oh, now you're in this new program, and he didn't understand why. He didn't understand why he was automatically put into a program without his acknowledgement. So he felt it wasn't anything that he had chosen to do. And he then had to seek out a new primary care doctor within Cal Mediconnect. And within this interview, I think he just expressed feelings of frustration in general over just being told that he was in a new plan. He was an older gentleman. He had a lot of other medical conditions, and he had a lot of specialists already that he had in his network, and just felt I think he just felt generally frustrated by the fact that he had no control over what had happened. And this is another example of a participant who, because of her limited understanding of Cal Mediconnect, felt that her options and her choice were also a bit constrained. The healthcare plan told us that enrolling in Cal Mediconnect was obligatory. Of course, they also say that I can get out whenever I want, but they told me that Cal Mediconnect was starting and that everyone that had Medi-Cal Medicare would be enrolled, so they just enrolled us. So this woman was approached by a healthcare plan who they encouraged her to enroll in Cal Mediconnect because she was a dual eligible consumer. They said this would be better for you. There's additional services and benefits with Cal Mediconnect plans. So she didn't understand. She did understand that she could have an option to opt out, but didn't, from her perspective, get all the information that she needed to make the choice for herself. She felt that she was encouraged to enroll and didn't have all the information in front of her to make a decision. So our last theme was disruption to existing care. Across the board, all consumers, no matter what their medical condition or the gravity of their disabling condition was, they expressed that it was important to maintain continuity of care with their providers. Those who anticipated disruption in their care, whether it be their relationship with their medical equipment provider or their primary care provider or pharmacy, they felt that if they thought there may be a disruption because they joined Cal Mediconnect, they were more likely to opt out of Cal Mediconnect. So this is an example of a woman who she saw many specialists from many leading medical institutions. She had suffered from a traumatic brain injury a decade before. She had some spinal cord injury. She just felt that she needed a very large network of specialists with her current care. And so when she was going through the process, she received the envelope in the mail, and she was going through the process of whether she should enroll in Cal Mediconnect because of these extra benefits, like transportation for non-medical services, vision, and some extra dental benefits. She really had to weigh the option if those benefits outweighed her existing relationships with her primary care providers and her specialists. And so for her, it was she didn't want to change her doctors at that point. She had had a long-standing relationship with most of them. She stressed that they knew her background without even having to look at the medical charts. And it was that relationship with her doctors and how much she trusted her doctors that she didn't want to lose that relationship. And I think that was something that was across the board for most of our consumers. And so there were some study limitations in this qualitative study. It was a small sample. We had 53 participants in the first phase, and we had 36 participants in the second phase. So it was a smaller sample, but I think one of the strengths of our study was with every interview, with every focus group we did conduct, the participants were very, very, very open with us and really detailed their past medical histories or their, what was going on in their lives at the time in terms of the Cal Mediconnect enrollment. I think that really allowed us to obtain a rich set of data because no one really held back. They really were really open with us about their frustration and their experiences. Because of the recruitment process, we do have some self-selection bias. We did, I think, for the most part, consumers that responded to our inquiry for one-on-one interviews and focus groups, for the most part, had some idea of what Cal Mediconnect was because they were willing to talk about it with us. And I think for some of them, they were the more engaged type of consumers. They had resources available to them. They knew where to access community-based resources. I think they felt more comfortable talking to someone about Cal Mediconnect because they knew it was something they experienced and they had a story behind it. So for some of our consumers that were, some consumers we did interview were the more passive type of decision maker, but we weren't able to really, it was difficult to access those types of consumers who don't have access to those community supports and maybe are less engaged in the process overall. And it would be great to hear more from what their experiences are when they're less engaged and maybe more removed from the entire process. And thirdly, the findings are not generalizable. As we know, LA is a very, very diverse county, and as there are other types of integrated programs going across the country in other states and other counties of California. But I feel like that because of the small sample size and the diversity of LA County, the findings are not generalizable. And now I'm going to switch it back to Dr. Keatsman to talk to you about policy recommendations.
And that last slide reminds me that it's important to understand that what we're presenting today is really just a few select examples, right, in terms of the findings. These are consumers, participants in our study that sort of represent some of the bigger themes that we found. But to that end, in addition to this policy brief, which is very limited by nature, it's a short piece, we do have individual case studies and composite case studies that are attached to this policy brief. So if anybody's interested in learning more about individual examples of consumers in Cal Mediconnect or who were faced with this decision, those will be posted on our website, along with composite case studies, which look at groups within the larger sample of 53 or with a focus group. So we look at younger consumers, we look at Latino consumers, etc. And we're developing those, so more to come. That's not an advertisement, but I just wanted to sort of put this into context, what you're hearing today. There's a lot more, which is the nature of qualitative research. So a little bit about what do we do with what we've learned from these consumers. The whole idea of this project was to document their experiences and their preferences for care. And there is a very actively engaged network of stakeholders in Los Angeles and throughout the state who've been working with this population for a long time before the demonstration program even rolled out. And so I think we're not the only ones who are trying to think, how can we make things better in a future iteration of this, or if this continues and expands to other counties. So with the healthcare system moving more in general towards person-centered care, right? We hear about person-centered care all the time. There's a lot of focus on how to involve consumers when they're in the healthcare system, when they're getting care, get them involved with care planning, get them to set their own goals and so forth. But I think now what we need to do is think about engaging consumers a little bit more upstream. So why not engage consumers to also get involved with disseminating information about healthcare plan options, get involved with that process, get involved with the planning, because this group of consumers that we were faced with the decision, and a lot of them clearly were not well informed when they had to make that choice. So we've learned from the consumers in the study that the complexity of the information about Cal Mediconnect and other healthcare products is a barrier to informed decision making. So we need to ensure that materials in future rollouts of programs like this are simpler, that they're easier to understand, available in all the necessary languages, and provided by trusted sources. And the question is really, who's better to determine that than the consumers themselves? They need to be the ones, in my view, to decide, to tell us what is a simple document, what should it look like. We learned from our participants that they generally want more clearly stated information about how a particular Cal Mediconnect plan would be responsive to their particular health needs and to their geographic location. That was also very important. So where are my providers going to be? How can I access care? And what do they know about my conditions, right? Some also talked about the value of presenting information through personal testimonials, right? Also known as word of mouth, or it can be more sort of, I'm sliding through my slides, whoops, sorry about that. Yeah, so it could also be more formalized, right, where health plans could post personal testimonials of members who are satisfied. And so our consumers said that those were really valuable to hear from someone who's actually in the plan, to understand more about what it really is. And of course, we need to make these information sources in various formats. The preferences in our group were really varied. Some people wanted print, some wanted electronic, some people wanted phone calls, others wanted in-person. And so I think there really needs to be multiple formats made available to get information out in all of the ways that people might be better positioned to receive it. And again, we heard that consumers typically want to hear this from somebody who they already trust. And so given that, I think health plans and community-based organizations could collaborate to train people that have been identified as trusted sources by consumers, and that they can become the vehicle for providing this information. And this could be, like a model that's used for Covered California, right? The Covered California's Navigator program. Also, given the diversity of this population, extra efforts are really needed to involve trusted community organizations that are in ethnic enclaves in Los Angeles. And these are areas where community organizations already have a history and a relationship with the consumers. So they're already more likely to be a trusted source of information. By delivering this in ways that are trusted, that are culturally appropriate, obviously in the right languages, there's going to be a better chance that consumers are going to really understand and access the healthcare options that best meet their needs. Secondly, policymakers, administrators, planners should identify and implement the least disruptive pathway to enrollment and to optimize consumer choice. And optimizing consumer choice sounds really great, but what's interesting, it's sort of a conundrum here, is that having too many choices can actually overwhelm actually being able to make a choice. So here we had 5 health plans. We had this, it was a simple form that had been reviewed by stakeholders over and again, and everybody tried to make it as simple as possible. But at the end of the day, it wasn't so simple, right? It was confusing for folks to understand. I'm in, I'm out. I have to choose a managed care plan for my long-term services and supports, but I could take out, I could keep my Medicare benefits separate. It's like, whoa, a lot of folks don't even know what's the difference between the Medicare and the Medi-Cal side, right? That's kind of invisible to consumers often. So most commonly expressed interest of these consumers was to preserve their existing network of care. And the Cal Mediconnect program does provide continuity of care provisions. So it's 6 months for Medicare providers and 12 months for Medi-Cal providers. But the fulfillment, in order to continue with those providers have to eventually agree to contract with a managed care plan. So there's a big question mark. That's a short-term continuity of care. These are folks that maybe have been with their network of care for 10, 15, 20, 30 years. So there's a real gap between the policy version of what continuity of care means and what the consumer version of staying with established trusted providers means. So rather than have these consumers change to a plan, a new program, a new plan, why not have someone coordinate what they already have? And it's interesting that the Washington State example of the duals demonstration, they're using an integrated managed fee-for-service model. It's showing signs of success. Now, of course, the demographics are completely different, state of California, state of Washington, so we can't compare them on that front. But in terms of the concept, under this model of care, consumers continue to have access to the same Medicare, Medicaid services and benefits, and they may also be connected to new benefits and services that fill gaps that they might currently have. Enrollees work with a personal care coordinator, and that person helps them develop and manage their care, their care plans. And they work with what they have. And this is, I think, especially important for the most vulnerable of our participants, of our dual eligible consumers, the people with the highest level needs, the most complex needs. Consumers in the Washington model also gain additional benefits through the health home, the Medicaid health home that exists in Washington State, including transitional care services, mental health services, and referrals to community supports and services. And these are all things that are part of the Cal Mediconnect plan too, but you can see the difference. One is really working, the Washington model is working with where consumers already are, and then they developed care coordinating agencies that help with these care coordinators to work across consumers' a set of benefits and services. So in the future, when we're considering new programs for dual eligible and other vulnerable populations, I think that policymakers and planners might consider instituting something a little closer to this concept of a coordinating agency that works to streamline consumer care across what they already have. Finally, importantly, I think, and it's important to recognize that there are varying needs and preferences across the diversity of the consumers who make up the dual eligible population. We, in this small study, had really limited capacity to conduct interviews in multiple languages. But the dramatic opt-out rates that among certain ethnic and language groups in Los Angeles strongly signal the need to more carefully examine the unique experiences and preferences of these consumers. We also had about 25% of our sample were immigrant consumers, and the ability for immigrant consumers to make appropriate healthcare decisions can be additionally challenged by limited English proficiency, lower levels of formal education, immigration status concerns, conditions in their home country that may increase their fear here of government and of government-initiated changes. So community organizations, especially those that are already serving sort of ethnic, racial enclaves in Los Angeles and serving immigrant communities, must dedicate extra attention to identifying and addressing these needs among the dual-eligible population. So I will end on that note and open it up for questions. Thank you.
Okay, are there any questions in the room?
I have a question about the overriding concern of most Cal Mediconnect consumers about keeping their primary care provider in their network of specialists. Since this is so important to these consumers, what can Cal Mediconnect do to maintain as much as possible those relationships?
Well, I think one thing they can do is to involve providers, to really educate providers, just in the same way that the consumers needed to be educated to understand more about what this Cal Mediconnect program is. The providers also, especially in the early months of implementation, really didn't understand what this was. So if you want to invite providers to join your network, there needs to be incentive, there needs to be motivation, they need to see the benefits of it just as much as the consumers need to see the benefits of it. So I think that's one piece. We could get into discussion about, I think some of the plans have tried to increase financial incentives to attract people, but I think there's a more fundamental educational piece that has to happen so that providers can really see this as a good option for their patients, and so that they would be willing to join. And I think the goal, I think most people agree on the goal of this program, that we should have more seamless delivery of care, better coordinated care, to get better quality at the end of the day, better outcomes. But the process of transitioning to it was a bit rocky, I think, in California. Yeah. Did you want to add anything?
I'm saying, unfortunately, I think a lot of it from the provider perspective comes down to costs, administrative burden of having to contract with a new health plan. There's a lot more involved than just signing a piece of paper. So I think that just adds a whole other element. And so what these plans have to do is, once they have a new consumer that has a big network of specialists, they have to reach out individually sometimes to each specialist in each provider office. And they could be individual provider offices, they could be a larger network. So that's just a long process in itself to get either a big leading medical institution to join the program, or even just a smaller provider office. And so that was a struggle for a lot of in trying to get more of the providers on board.
Okay, I have an online question. Within the same line of argument, what can Cal Mediconnect do to involve caregivers and family members in this decision process?
Okay, that's a great question. The idea of care planning under the Cal Mediconnect program is that the consumer should be able to identify who should be part of their care planning team. If the consumer opts to have a care coordinator and a special care planning team. So they can involve family members, caregivers in that process. A lot of these consumers are consumers also of in-home supportive services. And some of those caregivers through that public program are family members, and some are not related. So I think that that the providers under that, whether they're family or not, should also get education about what the program is, what the benefits are, the pros and cons. And I think a lot of our consumers did turn to their home care workers or to family members at times to try to help tease out what is this and will it really benefit me. So I think they can play an important role. And I think it's even more so for consumers who may have limited cognitive capacity. Then, of course, the family members may take a much more central role in that. But again, it ideally under the person-centered planning process, it should be the consumer who decides who sits at that table, and if they want a family member, they may not always want a family member. That's true too.
So all of this education of providers, of caregivers, translation services and materials, it all has a price tag. And do you think that Cal Mediconnect needs to dramatically increase their budget for these activities? And if so, is there money for that?
Well, I think that is to some extent at the discretion of the managed care plans, right? I mean, they can choose to use. They're using money for marketing to get more information out about this program, and I think it's really more they weren't able to market during the first year of the program, but now they're able to market because the passive enrollment period has passed. So now it's a voluntary enrollment. So they have budgets for marketing, but the question is, what is that marketing? In my mind, the question is, what does that marketing look like, and who is it targeting? So those dollars could be used to really provide, produce more educational materials that go beyond the consumer and go to this larger network.
Okay, we have an online question. Given where we're at, is there a role you suggest for health plans in CMC enrollment?
A role for the health plans in the enrollment?
Well, I think health plans have their own, every health plan has their own marketing team where they can work to try to, increase their enrollment in the plan. But again, if you're not going, it's going to be difficult to enroll someone if they do have a large network of specialists or doctors that aren't in that Cal Mediconnect health plan. It's easier, and we didn't talk about this much in today's presentation, but if a dual eligible consumer had a primary care provider already in a health plan, and that health plan happens to be also one of the 5 Cal Mediconnect health plans in LA County, their transition is seamless into that Cal Mediconnect plan because their providers already within that health plan is already contracted. I think the larger issue just stems from enrolling is hard when you have such a diverse group of consumers in Los Angeles County, and also not being able to respond culturally enough to the diversity of the consumers and their needs. And so I think health plans do have a role to try to enroll more consumers, but again, like we've said, if there was any disruption in continuity of care, consumers are probably not going to opt into the program.
And just to add to that, to give you a little more context, when this was being implemented, the managed care plans, this is the first time that they've been tasked with providing long-term services and supports, if not directly through contracting with community-based organizations that have been doing this for some years. And so in the course of the years since before and during the rollout, there's been a lot of work done between the community-based organizations and the health plans. So I think that collaboration continues to be very important because that expertise did not exist with the managed care plans. And so in terms of communicating and reaching out enrollment, it's going to be, in my view, a continued collaboration with the community organizations to more effectively reach the consumers that they want to enroll in their plans.
So you alluded earlier to, or you recommended that one option that could be helpful is sort of respecting the diversity of dual eligibles. And in the initial rollout, did you have a sense from your interviews and focus groups that folks felt like information wasn't provided in a language they could understand, or that the people that they could seek help from couldn't communicate with them either because of a language issue or or there was some cultural inappropriateness?
So from our experience with the one-on-one interviews and the focus groups, there were, for consumers who were non-U.S. born participants and whose primary language was not English, they did experience in some situations they received a Cal Mediconnect notification in the mail that was not in their primary language, or they would call the Cal Mediconnect hotline and trying to get someone to speak to them in Spanish could take an hour up to 2 hours. And for some people, they just don't have that ability to sit on the phone all day and wait, or wait for a call back. And so there were instances where they had difficulty trying to get that information in a different language.
Yeah, and I know the state did provide these materials in multiple languages, all the threshold languages. They were absolutely required to do that, and that was done. But again, you have a product, but then getting it to the right people in the right place is another matter altogether.
I'm just curious if, in this, maybe the answer is no because of one of your recommendations, but were stakeholders involved in the process of putting together the information that was going out? And do you know if they used any kind of visual summaries of sort of what the different options are rather than a long narrative or something that was sort of more infographic type?
Yeah, I think the state really has made a lot of efforts to make things better as they went along with this rollout. And they did involve stakeholders all along the way. How robust that stakeholder engagement process is, I don't really know for sure, but certainly the efforts were made, and even at the local level, there is dissemination through local counties, working with community-based organizations. So efforts were made in that department, and the visuals came a little bit later. And they have a website called calduals.org. And initially it was sort of the bureaucratic forms, which were vetted, and people provided feedback on them to make them more simple and easier to comprehend. But then they came up with at one point they had a little YouTube video kind of thing. So they did try different strategies. I don't know if you've other
So
things.
I think with the initial rollout, like I said before, the information was overwhelming. And some of the people involved in trying to make that information as clear as possible were dual eligible consumers that were on these boards and were helping to help design too, because they wanted to be part of the process. And that was actually one of the participants in our study. She was involved in designing some of the information, and even she herself said she was confused when she didn't make her own decision. So it just makes the point that for anyone, it's a very Medicare and Medicaid already, it's a complicated process for people, and then I think to add another layer of complexity to that. And I think the consumers that felt like they had the most choice in this entire process was the ones that received one-on-one help, either through someone calling them on the phone or coming to their house and walking them through the process. I think that was the most helpful for them, and someone just coming to them and explaining it, face to face. I think that was the most useful. That also takes a lot of time and money, so I don't think that's going to be an option, but that was the most helpful for most people.
Any other questions?
I want to keep us on time, so I want to thank very much Catherine and Kate for their presentation. And again, please stay tuned for announcements of our upcoming seminar. Thank you.
Thank you.